good morning.
Good morning.
Good morning, Hector, Casey.
Good morning.
Good morning.
Dr. Alfonso. So we're here on another Friday at the Oxford Exchange, across from the beautiful University of Tampa, and talking about things that we see on a weekly basis. So, this week we've seen a lot of neat things. And one thing we realized that we didn't talk about or haven't talked about is what we refer to as abfractions. When we talk about abfractions in front of patients, like, they should know what it is. It's like a household term, right? So we will make it a household term so that you will understand what we're talking about with abfractions fully. So, as I like to do for my own benefit, is why don't you talk about abfractions as you learned them in dental school, and then I can add what I see clinically over the last 30 years on what my take on abfractions are as well. So what's an abfraction?
So the way that I would describe an abfraction, you'll typically see it on the crown of the tooth, right where it meets the gum. And the way we were
but do they understand what a crown of the tooth is? Because they're thinking crown.
So it would be the part of the tooth that you can see above the gum.
Good.
So that would be the crown.
Okay.
Very good point. So it's a weak part of the tooth, right there where the tooth meets the gum, that starts forming a notch in it. And that's typically what we call the abfraction, that notch that you might see there. And the way that we were taught it in dental school, it's something that forms from excessive forces or collisions that occur on the tooth. So the collisions affect that weak point of the tooth and causes that portion of the enamel or the enamel crystals in that area to slowly wear away or chip away.
Great. So I agree with that 100%, and maybe you can envision how this would happen. Just thinking of the enamel as crystals, right? Because the enamel is kind of like tile, where the dentin may be more like wood. So the dentin wants to bend, and the enamel can't take too much bending.
Right.
So I always will show patients, if it's like this, you don't have too much bending, right? But if it's hitting like this, right where your finger will crinkle, that crinkle will turn into the abfraction. And that abfraction, patients don't even know they're there for the most part.
Yeah.
Some patients that are looking in their mirror, their makeup mirrors, may say, oh yeah, I know what that is, yeah. And they'll put their finger in it. And sometimes that hurts, sometimes it's sensitive. So we get a lot of people that come to us and they think they have a cavity. And you look at all the commercials on Prevenant and tooth-sensitive toothpaste that is driven, probably I would think, by these abfractions. And you see the abfractions a lot of times with recession, right?
Yes. So all those collisions and forces, they're affecting the tooth and what's around the tooth, the ligaments and the gum tissue. So the gum tissue will also go down, which is the recession they see. So yeah, very common to have both. And then when you have both, you have even more sensitivity, most likely.
And patients notice the recession. So when I talk about an abfraction, they're like, oh yeah, that's where my gum has receded. It's like, we're looking more at the abfraction, and as you say, it's all related. So one other thing that I've found is that these lesions, another criteria that typically is met when you form an abfraction, in other words, a perfect storm for an abfraction, would be when you have the collision and you also have the environment where you have excess acid. What do they teach in school about that? I mean, am I right or?
Oh yeah.
Okay.
Yeah. So the acid component is very important to understand because whether you're getting acid from your own body intrinsically or if you're getting it from what you're consuming extrinsically, the acid will be affecting your teeth, and that can kind of wear away at your enamel, especially if you already have an abfraction lesion in that area of recession. So the combination of the two, the abfraction lesion, which has been forces that chip away at the enamel, and exposing more of that softer part of the tooth, as you mentioned, the dentin, will be more susceptible if you have that acid in your environment.
Okay.
And so the acid will also deteriorate that area and kind of make that notch bigger or start wearing away more at the tooth.
Yeah, and so you can look at these and tell sometimes whether it's more from acid or if it's more from the collisions, because the ones from the collisions will be kind of deep clefts. One from the acid would be kind of washed out, right?
Yeah.
And it is kind of surprising and we've talked about acid a lot, GERD and whatnot in our blogs, because we see so much of it. And patients are always surprised when you mention that, right? They almost look at you like, what do you mean, acid? I don't know if that's because they think that maybe you're inferring that they're bulimic, because that's not what we're talking about. We're talking about a chronic type of acid reflux, most of the time coming from stomach acid, GERD. And the other thing that we see is acid from the diet. So can you talk about what we've been seeing that's trending from acid in the diet? Why would that happen?
So it's the pH of a lot of these drinks that come out. Sometimes even you see it in people who do a lot of sports or exercise. The sports drinks and the energy drinks, they have a high level of acid or a low pH. So when you're consuming that, and let's say you don't drink it through a straw, let's say you just drink it and kind of hold it in your mouth, you're just leaving that low pH there, and it can affect the teeth.
Yeah, and I would add apple cider vinegar.
Oh, yeah.
And lemon in your water, right? So it's crazy. I mean, the amount of people that use apple cider vinegar, and don't get me wrong, I'm sure it has a lot of benefit because it's weird because it is acidic, but it causes your body to be more alkaline, but it's acidic on your teeth. It's very acidic on your teeth. So if you are going to use apple cider vinegar or lemon water, do it with some moderation, because people get carried away with this. And I'm looking at their teeth like they're complaining about the teeth getting yellow, and what's happening is the enamel is getting stripped away and they're getting closer to that wood or that dentin, and the dentin's darker. And they're like, my teeth aren't as white as they used to be. I'm looking at them like, well, because I can see through your enamel. You're wearing your enamel away. But again, we're talking about the combination of Abfraction and the erosion, the acid erosion that shows that, and you really lose a lot of volume of the tooth. So in this particular case, the teeth, they look like they had been melted by like a hot iron, right? Where it's just like you put up a hot, and it's like just worn away. And again, sometimes we see it very asymmetrical, and that's when we ask you, which way you sleeping at night. Somebody that's sleeping on the pillow like this, all those teeth on that side will wear away from the acid. So I guess we should talk about how you treat it, right?
Yeah, absolutely. So we would do a tooth color material composite to cover that, depending on how the size is. So like for the case that we're talking about, a lot of that was of the tooth structure and was worn away, and we had to build quite a bit of that
the
tooth
whole
back
tooth,
up.
basically, the whole front side of that tooth.
Yeah,
right.
but using the techniques that we've learned using particular systems, and we are able to build that back up with composite and bond to the remaining enamel and to the remaining dentin.
Right.
To keep that structure there, and not only does it make the tooth stronger and protective, it ends up looking really nice.
The aesthetic result is a nice side benefit as well. Yeah, like in this case yesterday, I think I would have probably crowned those teeth a while back, and that was because that's the best way I could have done it, because if I would have tried traditional bonding, that transition would be really difficult. To get the transition to in between the teeth and to get it to where you don't have a lot of seams, to where those seams turn into ugly stains, right?
Right.
And so sometimes when I would look at my bonding 5 years down the road, I would look at it and go, ooh, it doesn't look that good. The nice thing is about doing this with a BioClear technique is that it's seamless. It becomes integrated into the tooth, and we do that in lieu of a crown, which is a win for everybody. Because to be honest with you, I mean, to make a crown look like we can make the BioClear, it's very difficult to do. So we're attempting to reproduce nature, which is a daunting task, right? We really we strive for perfection, but if we can get an excellent result, then we're happy.
Right, and the BioClear matrix systems allow that.
Yeah, you can get an excellent result.
Mm-hmm.
What are the challenges with fixing these abfractions then? I mean, what do you have to watch? What's the downside of it? What do patients, you know what patients say is how long does it last? So,
oh yeah, absolutely. So it's something you have to maintenance. And so how many years would you give it if, let's say, we do composite BioClear? How many years would you say to them about how long it could last?
I say 5 to 7 because it's not like it fails in 5 to 7 years, but I may look at it on future recalls and say, you know, we need to like renew that restoration because it does start to require maintenance. And the type of maintenance that it may require is it may start to not separate, but you can start to see the difference, the transition over time, where some of that transitional part starts to chip away.
Right.
And it doesn't have to be totally redone. In fact, sometimes all you have to do is buff it and polish it, and you're good. And I had a case like that this week. I saw it, and the woman was complaining about what looked like a little pepper cot in the tooth or something, like a little black spot.
Yeah.
And I thought, oh, she thought she had a cavity. And I start to look at it under my loupes, and I go, oh, we can buff this out. We buffed it out in a matter of 20 seconds, and she's like, oh my gosh, it's like a brand new tooth, you know, and it was easy, it didn't take any time, in fact, it didn't even cost any money.
Yeah, that's wonderful.
So that's nice. But in general, 5 to 7 years, you know, nothing lasts forever, right? But what we think about is, what if you didn't do it? What would the tooth look like in 5 to 7 years?
Abfraction would progress. So you can start seeing something that started as a small notch or some of that enamel wearing away, and you'll slowly, over those years, lose more enamel, especially if you add the acid component.
Yeah.
So if you don't take care of it now and you give it those 5 to 7 years to progress, it will take away more of the tooth structure and make it a little bit harder to build back up and repair. And it puts that tooth, it makes that tooth weaker.
And certainly it's unsightly, right? So it's like, I always talk about the Grand Canyon effect, as the Grand Canyon eroded over 1,000 years, and with the loss of enamel, every time you're brushing, every time you're eating, and every time you're exposing it to more acid, which is just natural in your foods, it's just going to continue to erode away. Because remember, the dentin is how many times softer than the enamel?
9 times softer.
9 times softer, which is a real significant difference. And every time I see it, I want to fix it, because we are trying to do what? Trying to get somebody to 100 with all their teeth, right? And so it's like in our head, we're looking at a checklist of what is working counteractive to being able to do that. And certainly abfractions are slow leak.
Slow leak, yeah, that's a wonderful way to explain it, yeah.
But the nice thing is it's fairly inexpensive to fix, and it can be done in one appointment. And what do you tell a patient about how much will reduce the sensitivity?
Well,
if it is sensitive.
If it is sensitive, covering up that surface should reduce the sensitivity almost completely.
Almost completely.
It's a great option for someone who's suffering from sensitivity when they're brushing, when they're drinking cold drinks or eating, and covering up that surface. It is pretty conservative what we're doing, because we're not taking away more the tooth structure typically. We're kind of adding.
Yep. Yeah, it's an additive procedure. So that's a good point. It's like when I used to do these, I would go in there and kind of make the divot bigger. But I think what changed that for me was the micro etcher.
Oh yeah.
So that was a key component. And so if you're being worked on, you may hear us, talk about this micro etcher. The micro etcher is like a little sandblaster that really cleans the surface, to where if I use it on my fingernail, I know, in fact, sometimes I check if it's working, because I'll use it on my fingernail and it will make it frosty. And so what it's doing is it's creating a brand new surface. And on a microscopic level, it's really able to help the composite stick.
Yeah.
And the other thing that we've changed is, instead of just adding it to the actual lesion, we kind of taco it onto the enamel as well. And enamel, it hugs the enamel really, really well. So that adds some protection. So when it does want to flex, it has a little buffer that is going to enable it to harness onto that tooth better. And the other thing is the composite that we use flexes kind of like a hybrid between the enamel and the wood or the dentin. So it lasts a lot longer. So it's a kind of a no-brainer to do it if you're diagnosed with it, but when do you? Are there some that you just watch, or are there, because I know myself when I'm looking at it, the hygienist will say, okay, are we treating this? Sometimes I treat, sometimes I don't. Can you talk about what you think about when you treat or when you don't?
When we are seeing patients that have that, and yeah, we see it with the hygiene recalls where we come and see them, because the hygienist is seeing you very often, so they can see if this is progressing. But when we go in there, we take a look at the size of that lesion and the amount of recession that you have in that area. And I look at it in three ways that why you would go in and treat it. If you have sensitivity, if you don't like how it looks, or if it has become a larger lesion that's getting deeper or taking away too much of that tooth structure. Yeah,
that's a good point. And then I have a lot of patients that they're the type that are like tooth fanatics. And they can see teeny little one and they go, I want, because we fix one and they like it, and they go, I want this one fixed. And a lot of times I will look at it and I go, you know what, that is not progressed enough to fix it, if that makes any sense. So if it's a teeny little area, by adding a volume of composite on top of that, actually is counterproductive in my opinion, because it can create a contour that's not natural and can create an area that may be harder to clean. And so bottom line, it kind of has to reach a critical point at which I would fill it to where I think it's going to be in your best interest to do so. And so sometimes I'm talking a patient out of filling one because it's not at that critical point.
Right. And I think that brings up a really good question. Let's say you have them starting or you want to prevent them. What's something you can do?
That's a great point. And this is something I've only recently, within the last 5 years, been able to look at it, because we look at everything in terms of cause and effect, right?
Right.
Which is lovely in dentistry that you can do that, because you can look at the cause and get to the root cause of the problem and fix it so that it doesn't so it's sustainable. Or as I always say, I wish we could do that with our body with medicine, right? So back to the point, what you can do is reduce the collisions. So how do you reduce the collisions?
You got to move the teeth.
Yes. So if the teeth are colliding like this and you want them to fit together more like this, you want to be able to move the teeth in that way. And most of the time, form follows function. So I look at it, my eye used to say, something's not right there. And then I would see the abfractions and I'd like, what's not right? Now I look at it as a seasoned clinician. It's like, I see what's not right. It's like this, and it needs to be like this. And when I put it like this, it also looks better too. So a lot of times you look at a patient and the teeth are bunched up and they're kind of narrow. And they smile and you see the spaces between the cheek and the teeth. And the patient doesn't know exactly why they don't love their smile. And what I look at it is it's a win, because we're going to make everything broader, round out the arch. And guess what? We're fixing the shoebox problem. The shoebox problem that you've heard me talk about before is the lid is too tight for the box and it collides. So if you make the lid a little bit more expansive, that fits on the box without any friction. So that is case in point, and we see that all day long. And in those cases, we may suggest, because we're never going to push, but we'll just educate our patients on what's possible, maybe it's a good idea to look at moving the teeth. And in our case, we do it with Invisalign.
Yeah, and the acid component, it's seeing what's going on with your diet, removing the lemon water or being more careful if you're drinking it with a straw, that would be good, or limiting how much you do those types of acidic drinks.
Yeah.
And how about if the patient has GERD, or you're telling them about GERD and maybe they say, oh, I didn't think I had GERD.
Yeah. Yeah, to get that diagnosed and at least mention it to your physician, because again, it may be in your best interest if that's happening. Because I say, if it's doing that to your teeth, what is it doing to the soft tissue on the way up? Your vocal cords, the esophagus, your throat. It certainly leads to, it's a precursor for oral cancer.
Yeah, absolutely.
So I think we've done a good job on making Abfractions a household word for patients out there. And I think that covers the whole thing,
Mm-hmm.
right? If you have these issues, you can talk to your dentist about it and have it treated right. Thank you very much.
Yeah, thank you.